not just that patients should eat better and more, or they should just go home and exercise. We can tell them exactly how they should, and we'll talk about that. So again, as I always start, again, it's our responsibility not only to ensure our patients are cared for so they will survive till tomorrow, but also so that they will survive for a lifetime. And that is always our priority, is we need to be thinking every day how we're going to help our patients become survivors that go back to their families and back to a life that's worth living, and not victims, where even though they live and survive their illness, they are so debilitated that they can't live the life that they came to us to restore. And so again, the key message, right, is our patients come to us to get back the life they started with, so they can walk down the street with the people they love and hold their children again and live the life that they wanted. So the key message, right, of course, is surviving critical illness or cancer or surgery is like running a marathon. Who here has run a marathon before? Raise your hands. Who's run a race outside on the road? Who's run before? So you know, there's a few. So you know that you don't just wake up one morning and run a marathon. You have to train, you have to eat right, you have to prepare. And for our patients, surviving cancer and critical illness and surgery is the marathon of their lives. It's the most important race they will ever run. And so what happens when our patients run the marathon without the right nutrition and training, and how can we make it right? And to tell you about that, I want to tell you about a patient that is very meaningful to me. And his family asked that I share his story with you, because I think it illustrates how we can use some of these techniques for our patients. His name was Elijah, and he was an 89-year-old coming for surgery for rectal cancer. He had had cancer diagnosed. And he'd been losing weight for about 3 months. He'd had a 10-kilo weight loss because of his cancer, so he's malnourished when he comes to us. He's feeling a little more run down, but he's very active. In fact, just the day before surgery, he was up on the roof of his church, fixing the roof. So this is a very active 89-year-old who has a lot of quality of life. He's very fit. And he has a lot to live for. He tells me that he's just had a new granddaughter who was born, that he's having this surgery so he can be well enough to go meet her. So he's got a new granddaughter he's anxious to meet. And so the question is he ready for surgery? Of course, we know he's malnourished, and this is not optimal, but he goes to surgery anyway, as all is too common. And he did well for the first few days after surgery, but then the third day, he woke up with severe abdominal pain and rectal bleeding, and he was in shock. And so he was rushed to the CT scanner where ischemic bowel was diagnosed, and ultimately he went to the operating room. In the operating room, he had a cardiac arrest. His heart stopped. Now remember, he's 89 years old. He gets CPR for 2 minutes on the operating room table, and he's resuscitated, and his heart comes back. But he's very, very elderly, and now he's at a cardiac arrest. And so again, they fix his anastomotic leak, and he comes back to me in the ICU with an open abdomen after having a cardiac arrest and already being malnourished. And so the questions from the nurses and from the young doctors began to be, can we save this man? He's quite old. Perhaps it's too late for him. Perhaps there's nothing we can do for someone that's this old, that's had a cardiac arrest. And they began to ask, maybe we should just let him die. We should let him pass away because it's just too much. But we knew, the surgeon and I, that he wanted to live and he wanted to fight. He had a lot to live for, and he was a very active man. And so what are we going to do for him? How are we going to save an 89-year-old who's had a cardiac arrest, who's already malnourished, on a ventilator with an open abdomen? So again, the family and he agree they want to keep fighting. And remember, he's very active. So he wants not just to live, but he wants to go back to a meaningful, active life. So we not only need to save him, but we need to fight for him and give him back his life at 89. So how are we going to save this patient? What are we going to do differently, right, to create a survivor of Elijah, even at 89? Because the reality is, even patients that are young, that are on a ventilator for a few days, will have months to years of physical disabilities many times. And even major surgery patients who aren't in the ICU have significant physical limitations and disabilities. So these are critical for all of our patients. And why is it our patients have such difficulties with their quality of life after illness? Well, again, we know a patient can lose a kilogram of lean body mass a day after a surgery or after an ICU stay, and they remain hypermetabolic and catabolic for years, often after injury. Even a burned child will remain catabolic for 2 years after they've left the hospital. Again, Mother Nature never intended us to survive these kinds of illnesses. And they'll gain weight back, but it's mostly fat they gain back. There's probably dietitians in the room that have fed 40 kcals per kilo to their patients, and they don't gain weight. And so we need to be better for our patients. And the bed is a problem. Beds are as big a problem as the illness. If I lay down a 21-year-old in the bed for 28 days, they won't be able to walk. They won't be able to walk. Astronauts do those experiments. If you lay an elderly person down who's not sick, who's healthy, for just 10 days, they lose 3 times more muscle mass. So as we age, we lose more muscle mass. And if it's a sick elderly patient, they lose that much muscle mass in 3 days. So I tell my patients, I don't want to see you in the bed. They're evil during the day. Beds are for sleeping. During the day, I want you in the chair or I want you walking, not in the bed. Beds are for dying if you're in them during the day. So again, we have to be better if we're going to save this man. And to do that, we're going to need therapeutic personalized nutrition, good physical therapy, and prescription of exercise like professional athletes do it. And we can do this for our patients now, I'll show you. So what are our goals, right? We have to recover and maintain their muscle mass, and we have to keep them fit, their aerobic fitness, so that they can have the endurance they need to survive. And so if we're going to do that, we have to personalize the nutrition and the exercise, giving the right amount to the right patient at the right time. And to do that, we need to measure. We have to measure how many calories and protein our patients need, because one size does not fit all, and that's critical. If you can't measure it, you can't improve it. And this was a paper that I was asked to write on personalized nutrition. I'm happy to share with you if you're interested, that talks about how we can do this. So how do we make someone fit? How do we give back this fitness to them? So again, you can't look at someone and tell if they're fit. How many of you have run behind someone who you don't think should be running in front of you, but they are? And so you can't just look at a patient and tell if they're fit or not fit. And so again, perhaps it's muscle mass that makes them fit. And so we need to be able to measure muscle mass, and this is part of how we personalize what's happening to our patients. And so we have the skin fold waves, which aren't very accurate. We have CT scans. CT scans are the future. We should all be learning to use CT scan to measure muscle mass. It's measured at the L3 cut. You can use free software from Slice-O-Matic. Our dietitians in some hospitals do this. And you have to be able to do this. And how does it affect outcome? So we know that if you enter the ICU with low muscle mass by CT scan, you can see your mortality in green is much higher. I'm sorry, your mortality in blue is much higher. Survival is much better if you have muscle and much lower if you do not have muscle. So again, even just the muscle you start with is so important. That's why muscle is so important for all of us. As we get older, we need to be building muscle mass all the time. If you're a cancer patient and you start treatment for your cancer like Elijah, and you've lost weight like he has, your average lifespan is 8 months. If you've not lost weight or you don't have low muscle mass, you live 2 years longer. This is the impact that having a robust muscle mass has for us and our patients. So how do we measure this? Are there other tools that we can use at the bedside besides this TT scanner? And there are, of course, the ultrasound. There's new ultrasound technology called the MuscleSound that we can use at the bedside. Our dietitians do it. You measure the leg. We also measure the temporalis muscle. This is a very good mixed slow and fast twitch muscle. It's very easy to get at, very reliable. And so we have a muscle-specific ultrasound that can also give us muscle glycogen, muscle quality, and muscle fat, as well as muscle mass. And it actually is like taking a muscle biopsy. We get a lot of data from it. And it's a little probe about this big that plugs into your iPad and gives you muscle mass, muscle quality, and muscle fat in a few minutes. And so we hope all our dietitians and nutrition physicians will have one of these probes soon. It's very easy to use. It tells you if you've taken the image correctly. You can see we can teach anyone to do this. And this is a device that we are really excited about for the future of nutrition. It gives us a lot of information. And so again, in addition, of course, BIA is a technique that many of us use. And the new BIA devices are quite useful. The new generation BIAs give us phase angle and other critical measurements that can be very helpful in diagnosing muscle mass and other body compositions. And now we know that the new GLIM criteria say that muscle mass must be measured in all patients. In fact, insurers in the United States are asking for it to diagnose malnutrition. And so again, we need to be creating indices using TC scan and ultrasound to do that. And so again, this is the kind of data that we get and what happens to the muscle over time. And actually, the darker the purple, the more glycogen they have in their muscle. So we can actually tell if the muscle is using the nutrition we're giving the patient with this device. It's the first device I've ever had that can see if the patients are taking in their nutrition and using it for storage in their muscle. So what were Elijah's muscle measurements? So this is what his muscle measurement looked like. You can see his muscle in his leg was very small. That's the purple area. And even though he's very thin, he has a lot of body fat. So he has very low muscle mass and actually a fair bit of body fat, even though he's lost weight. And so this is the BIA measure and the muscle ultrasound measure that we get from a patient like this. And this is critical because if you lose 40% of your muscle mass, patients will get out of the hospital, but they won't survive. They won't live more than a few months. And so loss of muscle mass is devastating for our patients. It's critical we stop this. And so what about how much to feed patients? And how do we measure and personalize that? Because we need to do that. I'm going to do an exercise with you. It's late in the day. Everybody stand up. Everybody stand up. I'm going to ask you some questions. Okay? So we all agree that nutrition is critical for our patients. If you agree with that, stay standing. Okay, I'm going to let her translate that. For everybody who has patients on vasopressors in your ICU, would you ever give the vasopressors without measuring a blood pressure with a cuff or an A-line? If you would do that, if you would use a cuff or an A-line to measure the blood pressure on pressors, vasopressors, stay standing. If not, sit down. Okay, so we'd all do that. What about on a ventilator? Stay standing if you would check a blood gas or check oxygen saturation on every patient on a ventilator. We always would measure these things. If you wouldn't do that, sit down. Okay, so we all agree we have to measure things when we're caring for our sickest patients. Who here has a metabolic cart in your hospital? Stay standing. If you have an indirect calorimetry, stay standing. Who has one? One person. This needs to change. One person, right? So again, the reason nutrition doesn't get the respect and attention it deserves is because we don't generate personalized objective numbers like other specialties do. But we can now, and I'll tell you that we need to all be thinking about how we can get indirect calorimeters in our hospital so that we have numbers we can show our doctors that we work with, and that will give us the respect the other specialties have. So again, predictive equations are guesses. They aren't useful. They are right using an equation about a third of the time. It's worse than the flip of a coin. A third of the time you're overfeeding, a third of the time you're underfeeding. A third of the time you hopefully are right. This is not okay. So these equations are worse than flipping a coin. In fact, some of these equations are accurate only 1 out of 10 times. This is unacceptable. This is bad medical care, right? We can't do this. Overfeeding causes complications and death. Underfeeding does too. We need to be right, and every patient is different. So how are we going to change this, and what do our guidelines say? Well, our guidelines say we should all be using indirect calorimeters. And I'll talk about the challenges of that, but we know they reduce mortality. What just happened? I lost my slides. Did we lose a cable? I don't know what happened. Okay, we got it back. So we know from the data from multiple meta-analyses now that using an indirect calorimeter, perfect, saves lives. So when you go to your hospital and are trying to justify them buying you one, this is the kind of data you show them, because this saves lives. It's not just that it's a good thing to do. But the challenge has always been these devices have been hard to calibrate. You need a respiratory therapist. They're not very accurate, the older ones. They're very expensive sometimes. And there was a lot of patients you couldn't use them on. So we got a grant from FASPEN, a group of us from around the world, to work with industry to build a new, better, cheaper metabolic cart. And so we did that, and we validated it in this study. This device is accurate, and it measures in 10 minutes. It's much different than the old devices. The old devices took an hour to set up, and you needed a respiratory therapist to calibrate. These calibrate themselves in 5 minutes. So our dietitians do all of the measurements, and any physician, dietitian, or anyone else can do this. They're very small and compact, so they're easy to transport, and you can use them anywhere. They're very accurate. We have gone to great lengths to ensure their accuracy. They can be used in intubated and spontaneously ventilated patients, so anyone can use them. So we wanted to build the metabolic cart that we all needed, the indirect calorimetry that anyone could use. It measures in 10 minutes. And then the key is we need to use it throughout stay. You can't just do it once. Patients change throughout their stays. Their metabolic needs go up and down. So we need to measure twice a week in the ICU and at least once a week on the floor, and that's how we practice now. And then we need to account real quickly. They need more than 1 times metabolic resting energy when they're doing exercise, right? So we need to be able to account for their needs later on. And again, protein is critical as well as calories, right? We can't build a house without protein. You can't build muscle without protein, right? So the key thing for our patient Elijah is he's almost 90 years old. And so he has anabolic resistance. And that means as we age, it takes more grams of protein to build the same amount of muscle than when we're young, right? So he's almost 90, he needs more protein. Now, not all old people lose muscle mass. You don't have to lose muscle mass as you age, but he does more than just eat right to look like this. And we'll talk about that. So again, we can learn from athletes though. We need to take in protein as boluses. Who bolus feeds your ICU patients? Does anyone do that? Raise your hand. Not so much. We do that now in about half of our patients. That's a more physiologic way to gain muscle. And taking in protein at night when we're anabolic overnight is very key. And again, exercise is critical as well. And so again, critically ill patients are the most anabolically resistant. And so the combination of age and illness leads to our patients needing the most protein and then needing help from other nutrients and drugs like testosterone or HMB or creatine, which is something we use commonly. But getting to goal nutrition intrally is very difficult in our patients. And so we need to be starting parenteral nutrition sooner. And the other key message is there is no association of parenteral nutrition with infection or TPN with infection anymore. Thousands of patients studied in big journals you've heard of like New England Journal shows it's just as safe to put parenteral nutrition through a central line as saline. There's no association of any kind. And so the data would say now in our guidelines that it is the same as enteral. You can start enteral nutrition or parenteral nutrition interchangeably. They're just as safe. So if you don't get your enteral nutrition in, you start supplemental or parenteral nutrition within 2 or 3 days. They're just as safe, they're just as effective. And in fact now, data from a large study in JAMA Surgery, the highest impact factor surgery journal in the world, shows giving parenteral nutrition in surgery patients like Elijah reduces infection. So starting parenteral nutrition at day 3 rather than waiting to day 7 reduces infection in patients. We should be using it more than we are. That's critical. So again, he had poor tolerance, and so he was started on parenteral nutrition on the 2nd day of his ICU stay, which is critical. Because the average time to feed these patients is a couple days. And so that's critical. Let me get forward here. Okay. So what else can we do for this patient besides nutrition to help him survive and recover? Remember, he's 90, he's had a cardiac arrest. It's going to take more than nutrition to do that. Is nutrition enough to win the war for our patients? Well, it helps clearly, but it won't stop muscle mass loss. It will slow it down if you feed well, but they'll continue to lose muscle because they're anabolically resistant and they become catabolic, right? Mother Nature never intended us to survive these kinds of injuries at age 40, much less at age 90 practically. And so again, we have to defeat this catabolism because this is persistent in our patients and our calories won't go to muscle. And so we can learn from athletes like this who, of course, don't look like this because they eat right. They do more than eating right, right? They use anabolic drugs to help them, and our patients need that too. So the right anabolic agents, we believe, is probably crucial for our patients to recover. You don't use them in the first few days. You wait for the first few days. The patient needs to be catabolic and break down for the first few days. But then after that, there's a lot of good data, mostly in burn patients right now, that shows it saves lives to use anabolic agents like oxandrolone and testosterone. They have shorter lengths of stay, they have better muscle mass growth, they have better physical function. These are kids and adults that receive these, men and women, both. Do better because they get an anabolic agent. So I check testosterone frequently, and almost all the levels I check, often they're 0 or 50. A normal level is above 300. So I check total testosterone at about day 5 on all my patients. And what I found is it increases your risk of death if your testosterone's low. Even if you're a healthy man and your testosterone's low, your risk of death is much higher if your testosterone is lower. But in our patients, this is dramatic. These are hospitalized patients that they had testosterone levels measured with a normal of 250. And they're all over 65 like Elijah. Half the patients had a testosterone that was below 200, which is very low. And you can see what mortality does in a patient who has a low admission testosterone. Testosterone deficiency increases death. This is bad for you, whether you're healthy or sick. And it's dramatic. It increases death dramatically. So if you're going to do this right, how do you do it? So one question you're going to get, isn't it increasing cardiovascular risk of stroke and heart attack? The answer is no. It reduces your risk of having a stroke or a heart attack. That's true if you're healthy, and it's likely true if you're sick. This was a 43,000 patient study of men with testosterone deficiency done in JAMA. Patients who had their testosterone replaced had 30% less heart attacks, 30% less strokes, and 30% less cardiac events overall. For every man in the audience, this is a good motivation to get your testosterone checked, but for our patients, it saves them from these events too. And so what about patients who already have had a heart attack or stroke? This is studied as well. If you've had a heart attack or a stroke in the last year and your testosterone is low, if you get it repleted with testosterone replacement therapy, your chance of having another heart attack is 80% lower. This saves lives, reduces heart attacks, reduces strokes, even in people who have heart disease. It doesn't cause blood clots, it doesn't cause prostate cancer, none of those things are true. That was all old data. So again, this protects our patients and helps them recover. Why aren't we using it more? And so I check total testosterone. You don't need to check a free. They're always very low. Almost everyone's deficient. If it's below 300, I replete it. I use testosterone cypionate. I give 100 milligrams for 70 kilos, and I give it weekly instead of every 2 weeks because otherwise the levels go up and down. The half-life is 9 days. In women, I start 50 to 75 milligrams, and I'll do it for about 6 months. Again, men and women. If you have oxandrolone, that's better. It's purely anabolic. You can give it to men and women without a problem. So that's the best because it's an oral form. We don't have that in our hospital. I check the level at 6 days after the first dose. I want it above 500 in men and above 300 in women. And these are what I try to target. And so this is how you can do this successfully. The half-life is about 9 days. Of course, you got to feed them adequately as well. This is a paper we wrote on all the different kinds of anabolic steroid repletion. If you want to learn more about them, you can read this. This will tell you all about them. So this is the new paper on that. So again, we need to address all the different causes of our patients' weakness and muscle loss if we're going to help them recover. And again, if we're going to help a 90-year-old recover like Elijah, we have to check all these boxes. We need exercise, we need nutrition, we need them out of the bed, and we need anabolic agents like testosterone to give them back their quality of life. What about the exercise piece? I'm going to finish with that. How do you prescribe exercise? What can we learn from professional athletes to help our patients? Exercise for our patients doesn't look like this. It looks like this. This is what we're doing now. We use CPET testing or cardiopulmonary exercise testing the same way an athlete does to prescribe exercise heart rate intervals for our patients. I want to tell you about another patient we did this in. This is one of the first patients we ever did this in. His name was Joshua. And he had gotten burned. He had a burn injury. He was very fit. It was when I was living in Colorado. He was a biker, and he got a burn. He was out of the burn unit in 24 days. He did very well. And he went home, and he tried to go back to biking. And he couldn't get up the hill outside his house for months. He would be exhausted in a few minutes. And so he came back to us and said, how can I become active and fit again? Because I keep trying, and I keep not being able to do the things I want to do. So we talked to him and learned that he couldn't even bike up the hills outside his house. And so we did an exercise test like this. You can do it stepping in place as well. And the beauty of what this test tells us is it tells us both what the mitochondria is doing, that's where you utilize fats, and it tells you what the TCA cycle is doing, that's where you utilize carbohydrates. You can see how these pathways are working. This is what an elite athlete looks like when you test them. They can use fat in that red line up to very high workloads, and they can generate and use lactate very efficiently. They have a high mitochondrial density in their muscle. So again, this is the lactate clearance part. This is what an obese person looks like. They have a very low mitochondrial content. They can only use fat for a little bit of the time they're exercising, and then they immediately switch to carbohydrates and get tired when they burn their glycogen down. This is, what about our patient? This is what our patient's test looked like. He couldn't use any fat at all. at any workload. His mitochondria weren't working. This is mitochondrial failure, and lots of our patients have it, but we never test for it. We tested him twice. This was the first patient our athletic testing people have ever seen in their lives that couldn't use fat in any way, shape, or form. And thousands of patients, thousands of people. This is what happens to our patients and why they have persistent weakness. And so we put him on an interval training regimen based on his heart rate targets to get him back. And a few months later in orange, you can see he began to use fat again. And he began to be able to bike up the hill again. We were able to recover him by prescribing interval training with target heart rates. And so this is the exercise dysfunction our patients have, and this is how you treat it. Now he competes as a competitive bike rider. But he would have never gotten there if we hadn't diagnosed and treated him with prescription of exercise. So again, how many of our patients suffer this and never have it treated properly because no one teaches them how to exercise properly? This can be done before surgery too. Elijah could have benefited. We're doing this in our hospital now. This is another patient we treated. This is a 63-year-old who was very frail, coming for bladder cancer surgery. She'd been turned down at lots of hospitals. She couldn't walk across a room without getting short of breath. We put her on the bike and tested her, and we get her heart rate intervals. They get printed on a card. The card goes in the bike, and it takes them through an interval training program up to heart rate targets, and then she rests. She does HIIT training. And then we give them high-protein drinks with H&B. In this patient, in just 4 weeks, we increased her leg muscle mass by 1 kilogram, more than 1 kilogram. People who have never exercised before have the best response to this. We can do the best with people who have gone from no exercise to exercising. They have the biggest jump. And she gained a whole VO2 peak, 1 MET increase in her endurance. This is a huge increase in just 4 weeks that we're able to make for this patient. Again, this gives her a 15% lifetime mortality reduction if she can persist in it. So we have great effects by prescribing exercise very quickly. Not everybody can come to the hospital. The US and Brazil are big countries. We've now gotten a big grant from the NIH to do this training at home. So we bring in patients before they go home from the hospital. We test them, get their heart rate targets. We send them home with an iPhone and an iWatch. We teach them an exercise they can do, and they interact with a physical therapist over the iPhone who coaches them 3 times a week. It's like having a personal trainer in your house, and they coach them through this. This is what it looks like. You can do this in a hospital room. This is me doing it actually before I had surgery. This mask cost us $2,000 US. It's not expensive. It's a Bluetooth mask. We test all of our COVID patients, cancer patients, surgery patients this way whenever they're in our studies. And we hope to start a program soon. And this is the data they show us, the physical therapist sees when they're coaching them. Their interval heart rates go up and we want to bring them down, and we have to coach them to do it correctly. Our patients who are having bone marrow transplants exercise an extra day a week. They exercise 4 days a week, they like it so much, and they improve their VO2 peak by 25%. So and they work in a month, they get these dramatic improvements. So again, if you want to learn more about these are papers where we talk about these strategies and these modalities. And as we finish, what happened to Elijah? Remember, he's 89. He's at a cardiac arrest. He had an open abdomen and he's malnourished. Can we save him? He wants to live and he wants to go back to a life worth living. So what did we do for him? So we started him after he got off his TPN and was able to eat again. We started him on a high-protein drink with H&B. I think H&B and creatine are critical. We started testosterone for him. You have to correct vitamin D. If you don't correct vitamin D, patients will not gain muscle. Vitamin D is critical to muscle function. It takes 100,000 units of D3, not 2,000, not 50,000 in an ICU patient. So you have to give enough. So we corrected all those things. We gave him creatine, which we use a lot. It's a very, very evidence-based supplement. And then he moved on to also doing physical therapy. Oops, let me go back. So he did sit to stands. That's the best exercise you can do for your patients. This is the hardest thing for them to do and the most important. They have to be able to stand up. He brought in his own weights from home, his family did. And he was able to use them. So even after all these things, what happened to Elijah? Can we save this 90-year-old man? Well, I will tell you that 28 days after he had a cardiac arrest, he walked out of the hospital on his 90th birthday. And that's the truth. And his family wanted me to share this with you because he was a hero. It was the most memorable patient I've ever cared for. No one thought we could save him, much less have him go back to a life that's worth living. He lived for 2 more years at home. He met his granddaughter. He fixed the roof of his church again. He led the life he wanted when everyone else told us there was no way he'd even survive. This is what personalizing nutrition and exercise can do. You can save even the patients no one thinks you can save and give them their lives back. This is actually Elijah. His family asked me to share this picture. He passed away peacefully at home with his family around him 2 years later. And they've asked me to tell this story, so that's why I'm telling it to you today. So again, as we close, we have to train our patients for the marathon of recovery and illness that they're facing. And we have to be good examples ourselves. So we have to practice what we preach. We have to do this ourselves too. But we can create survivors of even the sickest and oldest patients and not victims, like Elijah. But we have to be better. We have to do better. We have to measure our calories and measure our exercise and prescribe it using metabolic carts and CPET testing and personalize it with anabolic testosterone therapy, things of that nature to save these patients. These are all the things we can do for our patients. There's many, many things. New technologies, new measurement devices, new ways to train patients to prescribe exercise and nutrition. These are many of the treatments we can give to our patients. And of course, we need to ramp our calories and protein up slowly. We need to use parental nutrition sooner. We need to be aggressive with our physical therapy, and then we need to be willing to use anabolic agents to help our patients recover, because otherwise they won't be able to use the calories and protein we're giving them. If you want to learn more, this is what Isabel was talking about, we have started an online nutrition fellowship that anyone in the world can participate in. And the best, and I think the most wonderful experts in the world are the professors in it. I got to pick them myself. They're the people I like to listen to lecture. And so we have a module that goes every week for about half the year, and you get to interact personally with your classmates. We have people from 13 countries, including Brazil, and 4 continents, so people around the world, and you get to interact with these professors. People like Meta Berger, and Isabel is another one of our faculty. I teach in it, many of the experts in the world, and you get to know them and meet them and interact with them and ask questions. And so we would love all of you to join. We'll start another course in January. We have also started a research clinical nutrition training program to teach people to do clinical nutrition research. And we'll have a set of courses that specifically talk about how to do research in clinical nutrition starting in the fall that you could sign up for as well. And we've gotten funding to fund, let me go back to that, fund 2 people a year to do research projects. We'll pay for your project, we'll help you with statisticians, we'll help you get to meetings to present them, whether it's ASPEN or ESPEN. We'll help you do all those things. And so we have a physician in Ecuador who's doing it, and we have a dietitian doing it. So we funding for nutrition and dietitians and nutrition physicians. And so we hope to start an in-person program where you can come to Duke and we'll teach you these personalized techniques as well. So in the end, if we do these things, we can take patients who look like this, have them walking on their ventilators like this, have them exercising in their beds like this. These beds exist. You can do curls in them, you can do leg presses in them. They're pretty amazing beds. This is the future of what we can do in the ICU. And then have them leave the hospital looking like this, like Elijah did. Or maybe like this, but at least like this. And with that, this is what we're left. I encourage you to share what you've learned today on social media so your colleagues can learn and they can learn to take better care of their patients, and follow on Instagram and YouTube. I have my lectures posted there for free. And I'm happy to send you the papers or the slides. If the slides may be the best, I'm happy to share these with you. If you want to email me, I will send them to you. With that, I'd be happy to take your questions. Thank you.